Alrighty, welcome back. Again, this is the Advanced DMT. We're using the Pearson's Advanced DMT, a clinical reasoning approach. Second edition updated. We're going into chapter 6, which is communication and teamwork. Get through all these objectives. All right. So, as an EMS provider, you're not able to perform your role without good communication and good teamwork. It's required in every phase of the EMS call, from preparation on until you get your truck back in service. You have to have teamwork and communication skills. You have to have teamwork to coordinate efforts and achieve a high quality patient care. We are a team on an ambulance, uh, so that we come in pairs. And you, as an advanced provider, are now stepping into the role of team leader on a lot of this. So that may be a little different for some of you. We're going to talk about the principles of communication and understand how the specialized EMS communication equipment works, like the radios and repeaters and stuff like that. Communication. It's a message between a sender and a receiver. What are some of the factors that can impact communication? The environment, the sender and the receiver, the message, the channel or the medium. So, what about the environment could affect it? Right? It could be a noisy environment. Could be stuff like that. Sender receiver, maybe there's a language barrier, maybe the receiver has hearing problems. There's lots of stuff. Characteristics of the sender, right? You have to establish credibility, expertise, and trustworthy. You have to build that rapport. You can do this with your credentials. Hi, my name is Jim. I'm an advanced EMT with Joe Blow Ambulance Service. What's your name, sir? Your appearance, if you look professional, you'll be able to establish that rapport a lot better. You'll have more trustworthiness if you look like a professional. Come in, clean uniform, everything squared away, your name badge, all this stuff is, a very good appearance. Excuse me. You have to be easy to talk to, right? You have to convey that you're empathetic and you have a lot of respect. Um, if you're not easy to talk to, you're not going to get that rapport with the patient. You're not going to establish good teamwork with your partners or your work at the workplace. You have to keep an open mind. Don't be judgmental, right? No matter what happens, that's easy on most of our calls, right? Little lady falls down, goes boom. We're not judgmental, but what happens if it's a child abuser who got hurt or a drunk driver who caused an accident and there was fatalities in the other car? So it's not always easy to be a non-judgmental, but we have to maintain that. Maintain your composure and pay attention to your nonverbal communications, right? Um, like crossing your arms. Some people see that as a form of hostile or you're not paying attention, rolling your eyes, looking the other way, the expressions on your face. You have to pay attention to those nonverbal communications. What about the characteristics of a receiver, right? They have to have personality, intelligence, self esteem, language, stress, use active listening. So you will be both the sender and the receiver in any conversation, correct? You ask a question, they answer, or they're talking to you, you're a receiver. So you have to show these characteristics. You're going to exchange information in the way that you'll both understand it, right? So we can't always talk the same to every person. Some people are hard of hearing. You have to do some different things. So you may have to adjust your communication skills. Maybe there's a language barrier. I know if you read your book in the chapter, it says hospitals have translators readily available, where EMS usually don't. But there are a lot of apps out there. Some of them you have to pay for, where you can hit this app and it'll actually call a translator. Or there's always Google Translate, which isn't always the best, but it may be able to help you through it. Communication channels can be both verbal and nonverbal. We're going to limit our interferences, which is like technical issues, problems with hearing, seeing, speaking, intruding thoughts, feelings, or environmental noises. culture differences and language barriers. They're going to try to limit these interferences. Um, so it's always a good idea in your community that you're going to go to work for, that you learn what kind of diverse culture is there. In my area, we're starting to get a larger Hispanic population. So we know that eventually, or there's a good chance that you could run a call where they're like a Spanish speaking Hispanic person. Um, but other communities have different cultures, Asians, Middle Easterns. So you just learn the culture that you have, and go from there. You may have to. The book even recommends that maybe you go do learn that language. Um, so that could fix some of the problems. Feedback. The receiver sends information back to a sender about his understand. He can nod his head. He can respond verbally. Um, and sometimes you're going to ask for feedback to minimize misunderstanding. One thing that I could see here is when we're talking to medical control, uh, we may respond back what the doctor said to give him feedback. Team dynamics and communication. A team is a group of individuals with a specific goal, and everybody on that team needs to know what that goal is. They need to know their roles, right? Um, and requires effective communication. So we have to have a role. You have to have a leader. Uh, you, so, and it's not just your team as well. We have other public safety officials we work with. So, and those are all part of our team. Your dispatch, part of your team. So you communicate with all these people. Um, there, I just talked about it extends beyond the EMS scene. You're talking dispatch, medical control, um, communication through technology. We have to confirm and repeat. Some technology would be like radios, computers, cell phones. Remember that the communication technology is rapidly evolving. What we have today will be obsolete in a few years, and somebody will create something different and nicer and easier to use, possibly. The FCC is responsible for oversight in EMS communication, right? They approve the equipment standards. They assign the frequency, what frequency can run on. They'll license the base station, like your dispatch center. They'll assign call signs, what your radio call sign is. And they also issue and enforce regulations, like no profanity, stuff like that. They oversee all that stuff. Or the Federal Communications Commission, the FCC. Uh, EMS system communication is essential to having a maintenance plan and a backup plan. So, what happens when your radio system goes down? How are you going to communicate? Do you go to cell phone? If you're using more of the cellular based radio system, do you go to VHF when you go down? So you got to have a backup plan because something will go wrong and it will go down, right? So you need regular maintenance and a backup system. And you have to have a system so that multiple agencies of jurisdiction could can talk to each other and understand the process and the standards, right? So we're trying to make this uniform standards and process. So a lot of times when you need to talk to multiple agencies, National Fire is one we use in our area quite a bit. You've got iReach, iFern that you can talk to like people on, but you need to establish that beforehand. And usually that is our dispatchers are really good. Our 911 dispatchers are really good about saying, "Hey, everybody go to Mavis Red, which is a channel in our area." So we'll all talk on and free up like the National Fire Channel. EMS radios systems operate on an assigned radio frequency or channel, right? This is a public channel, however, and can be scanned in Scannerland if you're using VHF. Now, if you're using private or digital or cellular can still be um, scanned on scanners, but a lot of times they're encrypted. So you have to have a special code to open up that frequency. Push to talk systems where you have to push a button, wait a second, and then it opens up the channel, and then you talk. And then while you have the channel open, nobody else can talk, right? So this is like our FM radios, your little walkie talkies, portables, stuff like that. Radio traffic is messages that are sent back and forth in communication in plain English. Talking about communicating and documenting time. Times are used for a number of reasons in EMS. We use it to keep track of our times, how long it took us to get there, how long we were on scene, how long it took us to transport, how long it took us overall to do the call. It's all there for statistics and for QAQI stuff. And almost all of them use the 24 hours of military time. So, for example, 6:30 would be 6:30 a.m. would be 06:30. 1:45 would be 13:45, and so on. So what you do there is it's normal 12-hour clock till noon. So it starts at midnight at 0000 or 0000. And then at noon it's 12 whatever 12:30. But at 1 o'clock we just have to add 12 to that. So anything afternoon we add 12. So 1 would be 13, and of course 11 would be 23. What kind of communication equipment do you have, right? We have base stations, which would be at our 911 dispatch centers, our internal dispatch centers. We'll have base stations. Base stations are more powerful radios. Usually, I think the book said up to 150 watts. So they have a further range. They have a fixed antenna at site for better transmission and reception. A mobile radio is like the ones you have in your truck, a VHF radio that you would have in your truck. It has limited range, not as quite as good as the base station. I think they're up to 50 watts in power. It has an antenna too, which is attached to the external, usually the top of the ambulance. Portable radios are the ones you carry on your side. Very limited range, very low powered, 1 to 5 watts. They're good for talking back and forth to each other outside the truck, close range. Now, a repeater is a device that uh, listens for your frequency, lower powered frequencies like a portable or a mobile, and then it powers it up and sends it out across a different frequency. So you can use, there are fixed repeaters that we see on like towers and stuff like that, or there are mobile repeaters that you can have in like your ambulance. That if you're outside the ambulance, you use your portable, the repeater will pick it up, uh, add more power to it, and send it out so you can get out further. Digital equipment would be like push button consoles and stuff where you can, or computers, stuff like that. Some ambulances have it where you can push a button and it says you're en route or you're on scene or you're en route to the hospital, so you don't have to actually get on the radio and talk. It's the digital equipment will do it. Cellular phones, of course, we all know what that is. Of course, a lot of radio systems now are using cellular, uh, so they're like a push to talk cell phone sort of, and a lot of companies have went to that, which are really good because if you got cell phone reception, you can pretty much talk anywhere, right? And tablets with cellular capability. Again, you can do the push button stuff with that. And a lot of EMS companies have went to tablets with cellular base just for like their PCR and to use as a mobile hotspot for like their cardiac monitors and stuff like that. Here's a good picture of an overall system. How the portable hits the repeater. Repeater bumps it up, sends it out to like another repeater. It goes to dispatch center, which is going to have a base station or our mobile unit in our ambulance. This is an example of a base station. This would be like a 911 or dispatch center. Some guidelines for radio communications. You make sure the radio is turned on, of course, and it's on the right frequency. Believe it or not, that happens quite a bit. That you're on the road frequency. You're on whatever your dispatch frequency is. You flip it over to like Mercy to talk to the hospital, and forget to turn it back. And now you're telling the hospital that you're en route to wherever. Listen before you start transmitting to make sure that nobody's talking on the channel. You're going to push the PTT button or the push to talk button. Wait a second, and then start talking. Because if not, it takes a second for this to engage. So you already start your conversation, and the receiver or the person receiving it will miss part of your conversation. Hold your microphone 2 to 3 inches away from your mouth. Speak clearly in normal volume. You don't have to yell into it. First, you can state the name of the entity or unit you're calling, and then followed by your unit. So, for example, if I'm going to call St. Anthony's Hospital and I'm Med 15, it would be St. Anthony's Hospital Med 15, right? You wait for the unit to respond. They'll say go ahead or stand by, which means you're going to wait for them until they're ready. We're going to try to keep our transmissions down to 30 seconds or less without pausing and deliver the information in an organized format. Talking about therapy, communication, interviewing a patient, right? Difficulties, culture differences, language barriers. We kind of talked about that earlier. Um, it's always a good thing to use surnames like sir, ma'am, Mr., Mrs., unless they tell you, like, hello, my name is Jim. I'm an advanced EMT with Joe Blow Ambulance Service. What's your name? My name is Sally, whatever, Mrs. Whatever. What's going on? Call me such and such. So after she says that, I would address her to whatever she wants me to call her. You may have some uncooperative patients, right? Maybe they didn't call the ambulance. Maybe they don't want to talk to you. So these people are harder to communicate with. Possible solutions: you can speak calm, clearly, and with non-aggressive tone, and be courteous and compassionate. Uh, Interculture and language considerations, increased culture diversity in communities. We talked about this. Communication can be very different across cultures. Meanings could be different. What something means here in our American English could be totally different in their culture. So be careful of that. Be cautious of that. Uh, we can have language barriers that can impact communication. We can use interpreter services, family, smartphone apps, and tablets. Um, Sometimes family's great. Sometimes family's not. Maybe their English is very broken and they're not getting quite the understanding that we want them to, and they're asking the wrong questions. Not always, but sometimes it happens. We have to build that trust and that rapport. Here they're using a family member um, to communicate with the non-English speaking patient. We're going to try to control the environment, provide privacy, control the noise, turn your portable radios down, your mobile radios. Some people do not want to talk around their family. Some people need their family, so you have to just kind of figure it out, see how it's going, see what works best for your patient. Non-behavioral communications, posturing, gesturing, facial expressions. We talked about all them. Um, you have to be careful of that. Personal space, right? Not everybody wants you up in their face. So I think the book said 18 inches is a good start point. Some people want maybe 2 to 4 feet. Touch may be a sensitive issue. I know a hand on the shoulder or on the forearm or on their hand shows a sign of sympathy, but not everybody likes that. They don't want a stranger coming in, groping them up, filling up on them. So be careful and just kind of read your environment. Good verbal communicating. You have to have active listening, be available. The open ended questions, these are the ones that you're not going to limit the range of the options. You're going to ask them, like, so what's going on today? And let them explain in their own words. Closed end questions is really the yes no questions. Do you have a history of diabetes? Do you have high blood pressure? Right? Does it hurt here? Those are closed ended questions. Sometimes we have to go to more closed-ended questions when we have a patient that's really elaborating on stuff or a chatty box, so to speak. So sometimes, to speed up things, we have to kind of, you have to be a little cautious with that though, because that could uh, actually make some people mad. So you have to be very cautious with that. We shouldn't use leading questions, which will suggest an answer. I teach this in like my EMT class when you're doing your patient assessment. When you ask about chest pain, you don't ask them if it does. I don't ask them if it's going down their left arm or up in their neck. I'll ask them point to where it hurts and is it staying there or is it going somewhere else? That way, I'm not leading that on. Does it feel sharp? Yeah, it does. Well, actually, it was crushing. So. No leading questions. Make sure they're understanding. Sometimes you have to ask them. So, are you understanding my question? Clarify information. Uh, confrontations. Confrontations is pointing out inconsistencies in the patient's communication. Facilitation, reflection, silence, and summarize. Pitfalls of communication is multitasking. Sometimes we're thinking way ahead because we know we're thinking of the questions we need to ask now. We're not paying attention and we miss something. Requesting explanations. Sometimes we overload the patient with information or questions, so give them time to think through it, answer a question, one question at a time. Give advice and opinions. Checking subjects. Interrupting, that's never good. Let them answer. And false reassurances. We never want to give them false reassurances. We always want to be honest. We don't want to tell them everything's going to be all right. Because one, we don't know that. And two, what if it isn't? Right? How about specialized patient communication situations, age related, psychosocial characteristics? Um, People, when they get older, they tend to get a little, some get a little grouchier. Some are more homebodies or more internal. They don't want to be around people. Uh, some people see doctors a lot and they don't want to see you. So it's all could be age related. What about the young? What if very young, right? They don't want to be touched by a stranger. Sensory defects and cognitive impairments. So they could have like, hearing problems, problems with their eyes or sight. Cognitive would be maybe they're starting to get a little dementia or they have Alzheimer's, stuff like that. We're going to start our communication, however, with our patient, right? If we're able to communicate with our patient, we're going to start with them. Sometimes the family likes to interfere, but we need to talk to the patient. What about hostile patients? Your safety is number one. We're going to try to verbally diffuse this situation by using strategies, but sometimes that don't work, and all else you're just going to clear the scene and call for PD, right? Uncommunicative patients, we're going to try closed-in questions to gain their trust. These are patients that won't talk to you, so maybe we'll try some closed-in questions like, "Are you hurting? Um, does your belly hurt? Do you feel nauseous? Do you feel like you're going to vomit?" Stuff like that. Documentation, patient care report. This is your PCR. Most of them are ePCRs now on electronic. There are several different programs out there. There's like ESO. There's a whole bunch of them. Zoll's got one. There's tons of these, depending on what your company uses. Um, this is a continuum of care, right? Information for billing, insurance claims, and statistics will come from this. It is a legal document, and it also provides data for research and education. So this becomes part of the patient's permanent medical record. We also use it for billing purposes. We use it to collect data for the state and for nationally. And like I said, it is a legal document that can be used in court. This is an electronic or an ePCR. Standardized data collection, types of patients who seek EMS. They're trying to figure out the demographics, types of provided cares, what's a common call, chest pain, shortness of breath, outcomes. They'll follow them through the hospital. The National EMS Information System, or NEMSIS. It's a database for patient information and administration information. Sections of the patient care report. You have administrative information. You have the patient demographics, vital signs, narrative. This is where we tell the story of the call and our treatment provided. Different ways you can chart for your narrative. SOAP is one of them. You use S as subjective. This is the information about the problem as is given by the patient, right? It includes the chief complaint, history of present illness, and symptoms. Here's a good example. Patient complained of difficulty breathing, started it 90 minutes ago. History of asthma, states that he has used his albuterol inhaler to relieve the symptoms. The O stands for objective. This is information that we observe uh, by the advanced EMT, such as vital signs, pupil reactions, response to pain, and other physical findings. Patient found prone on the floor in a pool of emesis next to his face. Did not respond to painful stimuli, but breathing spontaneous at 12 a minute. The A is our assessment. Your field impersonation of the patient's problem based on subjective and objective examples of suspected hypoglycemia. And P is the plan. This is how we're going to treat them and the transportation information. Example would be open airway with head tilt chin, patient unable to tolerate an OPA, oxygen at 15 liters via non-breather, IV normal saline to keep the vein open, um, left forearm 25 grams of dextrose, which now would be 10, but we'll talk about that later on. Level of conscience increased with 2 minutes. The patient remains A03, and then where we took him to. Chart is more of what a lot of people use. I know my company, we have a modified chart, um, and that's what I've used for years. It's usually introduced by your dispatch or how you found your patient. The chief complaint describes the patient's complaint, also includes the associated complaint and patient's pertinent negative. So here's a good example. Patient complaining of right upper quadrant abdominal pain radiating to the right shoulder for the past 2 hours with no provoking or uh, alleviating factors. So nothing makes it better or worse. Pain described as sharp and crampy and consistent. Patient rates pain 7 out of 10. Complains of nausea but denies vomiting. So there's your pertinent negative, right? She has nausea, but she's not vomiting. That's a pertinent negative. And what a pertinent negative would be is something we would expect to see with those symptoms, right? Like, for example, shortness of breath with no cough, or a cough that is non-productive. H is history. This is history of the present illness, or HPI, or the past medical history. And then we go into assessment. This is information for primary and secondary assessment and reassessment. R stands for treatment. So what did we do, right? And transport. That's how and where the patient was transported. So how did we put him on the cot, and which place did we take him to, and where did we take him? Cheated is a variation of the chart. Chief complaint, history, exam, information primary, and the secondary assessment. Assessment would be your field impression based on the chief complaint, history, and exam. T is treatment. D is disposition, which is your transport and transfer. Chapter 7 will have more symbols and abbreviations. Specialized documentation circumstances. So outside of the PCR, there are times that we're going to have to use specialized documentation. Uh, and then remember, your PCRs are legal medical records that are protected by HIPAA. Correcting errors on a PCR. In the old days when we had to write them, you would just put a single line through the air, initial it, and then correct it. Now you have to do an addendum to your narrative. Here's an example of the, if you're writing it out. Leave abbreviations PCR at a minimum, and make sure that you use abbreviations. If you use abbreviations, you continue throughout your entire career to use the same ones, because yeah, we want to use abbreviations that other people may understand when they're reading it, but really in the end, you have to know what that is. 3 to 5 years from now, if you go to, get called to court, you need to know what those abbreviations are. Mass casualty incident reports or special forms. When we have mass casualties, there are limited information about the patients, but they're not complete PCRs for every patient, because you may have 50 to 100 patients. So it gets minimal information for every patient. Patient refusal of care. These are specialized forms. Most EPCRs, you got them built into it. You have a refusal, or you do a refusal through your EPCR. You just have to check off some boxes and do some different things to make it a refusal, but they're there. If not, there are handwritten forms and documentation outside scope of PCR, right? There are some things we have to document that's not in the scope of PCR, like injury reports for you. If an injury occurred to the patient while you had them, there are specialized reports for that. All right, so the chapter summary. Effective communication, essential to every aspect of the EMS provider's job. Be aware of your verbal and nonverbal communication. Strive to improve your communication skills and teamwork. Establish rapport with patients and use therapeutic communication techniques. Be proficient in the use of EMS communication equipment and adhere to their guidelines. Breakdowns in communications can jeopardize your safety and that of your patients. All right, that wraps up chapter 6. We will see you again on chapter 7.